Welcome to another episode of Girl Talk with Dr. King. Today, we are talking about fertility, infertility, advanced maternal age, and we're going to explain what all of those things mean. Definitely going to talk about women of color who are dealing with these issues as well. Today, we have a very special guest. We have Dr. Femiyewa. She is a reproductive endocrinologist. Sometimes we call that a REI doctor. And she is going to explain to us her journey and some of those questions that you guys might have about fertility. She's originally from Nigeria, and she came here with a dream and with a plan. You'll hear her say sometimes, I was too young to be scared. So she took initiative. She came here, and now she's contributing to the world around her. The other thing that I want to point out is that this set looks a little different. That's because we are in her office. Her office is located in Rockville, Maryland, and she is a solo practitioner. So if you're looking for a reproductive endocrinologist, a specialist in fertility, then you found the right person. So sit back, relax, and enjoy the journey of fertility. Explain to our viewers what that is, what you do, like reproductive endocrinology. That's like a really big
I'm so sorry. Yeah. I know we roll it off our tongue.
Yeah. REI, whatever.
So I think that I liked the knowledge part. I liked the science part. Just studying and getting to the nitty-gritty of science, how the science of reproduction works. So that for me was the knowledge part.
Got it.
What was fascinating. Then the other part of it is I like helping people for me the other part is then my patients.
Yeah.
When you see your patients who are trying to get pregnant and they are struggling, and how can you help them? So then it went into, I like what I do because I'm helping people complete their families. These are people who, it's like they would have not have children any other way. And helping people who are saying, please help me. The ability to have a child is a right of anyone who wants it.
Yes, I like that.
You understand? So trying to help people who want to have children and they're suffering. So that part of me is just fascinating, and just helping people, combining that with the science. It's almost as if I'm in heaven. Yeah, thank you.
Did we say it at the same time? Well, I've been here 11 years. So I moved from Detroit, Michigan, which, I love Detroit, 11 years ago. And I've been doing an OBGYN here. I have been referring to fertility specialists that whole time. And you've been here 25 years.
Correct.
And we're just meeting. Why do you think that is?
I think that now it's only now that I'm starting to explore and expand my reach to other people.
Good.
Yeah, I think now it's just now that I'm expanding my reach to more people is what I would think. Yeah.
Yesterday, I spoke with the Coalition of 100 Black Women and the National Coalition of 100 Black Women. And I had a lot of questions about fertility, which was right on target because we're talking today. But I had a woman in particular that was looking for a reproductive endocrinologist of color. You are a rare breed. I think you need to know that if you don't already know that. And so we are happy that you're in this space.
Thank you.
But we also want to know that you're here.
Yes.
You know, I gave her your number, so hopefully she'll contact you.
Yes, please, by all means, yes.
But sometimes in our communities, people of color, we don't know what's accessible.
Yes.
And we're scared.
Yes.
And even when you say fertility, sometimes people automatically assume that you have to have shots or you have to have in vitro fertilization. Can you kind of tell us a little bit more about what you do other than those parts?
So I think the part that I enjoy doing is reaching out to people to let them know what are their choices.
Their options.
What are their options?
Got it. Mm-hmm.
I think that we don't have enough exposure. 'Cause for instance, you know, there's a lot of stigma with fertility.
Yes.
Like I come from an African background, right? And I have a lot of patients who are from either Asia, from Africa, from the Middle East. There's a lot of stigma with fertility, and they don't know where to turn to.
Yeah.
You know, they don't know who to turn to. So part of what I do is helping spread that word and letting people, demystifying and letting them feel comfortable and not ashamed, right? There's nothing to be ashamed about, and you can reach out for help.
Yeah.
You know, so that's the part that I enjoy doing.
What are some of those options? If someone comes to you, and of course we're talking general because every patient is different, I understand that, but what are some of the options other than just in vitro? Like, do you do IUI, which you can explain to me what that means, or do you just do timed coitus? Like, you know, what are some of the things that...
So some of the things you might surprise, it could, some people can turn things around. It could be their lifestyle, right? It's maybe their diet, it may be their lifestyle. So having them make those changes may improve their chances of succeeding. For instance, if people change their diet and lose weight, they might actually get pregnant on their own, right? So that's one option, lifestyle. Someone to talk to them about what are you exposing your body to, right? Other options, it doesn't have to be in vitro fertilization. It could be just they need to know about timed intercourse, right?
Yeah.
Are they using the ovulation kit correctly? Some people, I wrote an article in Medium, I'm sure you've heard of Medium.
Yes.
Where people can improve their chances of getting pregnant by using two modalities, such as either their LH kit, trying to use the ovulation kit, or on those, not just ovulation kit, the calendar, all those things can help. So those are the things that they could start out with. Okay. Start on the minimum first.
Least invasive.
The least invasive, and then you could gradually, you know, increase the complexity.
You have somewhere to go.
Yeah, you have the complexity.
Okay.
Yes.
So I'm an OBGYN and I'm on the front lines of infertility. So I typically see the patients first.
Yes.
And I do the full workup. I do a history, I do a physical, I get the labs. I even order the HSG, ultrasound.
Music to my ears.
All of those things.
Yes.
From a patient standpoint, what are some things that they would need to be prepared to see you? And from a clinician standpoint, what are things that you wish that we have done so that we can streamline the patient care?
Yes.
You know?
I just wrote another blog. I like to write.
I love that.
Yeah. In Social Media Docs magazine. Okay. And it's going to come out anytime now. And I talk about, I have an initiative. I call it the pre-test first.
Got it.
And my initiative is to educate not just the patient, but also my referring doctors. Yes. Please help me get their labs on the third day of their medical cycle, menstrual cycle. Yeah. The FSH, the LH, the progesterone, the estradiol, and the AMH. Get all that for me. If you can get an HSG, if they have a hydrosalpingo, start treating it. But get the HSG. Okay. More importantly, get genetic carrier screening done, right? A lot of people don't think about that.
We do that.
And, and I said, well, are you a carrier for sickle cell or cystic fibrosis? The reason is it takes a long time to get the results back. So if they get that started, by the time I see them, I'm just looking at data and I'm coming up with a game plan. And then another thing, if you really want to be super cool about it, get their partners to get a semen analysis done.
Yeah.
Because when they come to see me and they haven't had all that done, that's the first thing I have to do. And then by the time the results come back, it just adds a month or so to their journey. Because I can't really start coming up with a game plan until I have those essential things.
And time is
Yes,
of an essence when we're talking about having babies.
Yes,
The
yes.
semen analysis part, we typically would get it, you know, for the spouse. However, I've seen problems with insurance.
Yes.
So are they able to do that here in case, like how does that
I
work?
can't, unfortunately, I can't accept insurance for it either.
Okay.
Because I have to pay someone to come do it.
Got it. Okay.
And I think that the problem with semen analysis started probably, I've been in almost 20-some years now, over 20 years ago. Insurance does not put a lot of weight on a semen analysis, even though
So it's not just us, like it's a thing.
they just don't think it's important for them to pay for it, right? And if they pay for it, they don't compensate what it's actually worth.
Got it.
What they don't understand is, I tell patients, the semen analysis is actually a vital sign.
It is.
Right? I have picked up gentlemen who've had testicular cancer because something was off in the semen analysis, and I chased it down.
Wow.
Send them to the urologist, and then he calls me up. Oh, by the way,
Right.
you know,
And you don't even treat men.
and I don't even treat, but I have
Yes.
I have a colleague of mine,
Yeah.
Dr. David Fennick. Shout out to him and his
Yeah.
partner, Melinda Mendez.
Okay.
They're awesome. They're fertility trained urologists. There's actually a
Never heard of it.
Now you have.
Now I
The
have.
urologists that actually do a fellowship
For-
in fertility.
Okay.
That's who you want to be using when you have complications with men. And he and I have been, you know, partnering to take care of our patients. I have he and his partner's cell phone on my phone. They have mine. We
Yeah.
talk to each other
Okay.
because it's just that important. So I can call him and say, hey, listen, I don't get it. Why is the pH this or why is that? You know, what are you going to do for this gentleman? And he'll call me back and say, oh, by the way, you know, I found this person has testicular cancer, or this person has untreated diabetes, right?
From the semen?
From the semen analysis, okay? Well, you know, let me give you an example. When COVID started,
Yeah.
we started seeing gross abnormalities in the semen parameters,
Okay.
right? So then you can say, we know something's off. So you can, you know, and it takes a while to come back. So your semen analysis is actually a vital sign.
I did not know that.
It tells you the body, you know, your sperm is in an environment that is not conducive.
It's not well.
That's not well. That's not well.
Yeah.
And that's the first sign. So when I start to see something a little off, now that I start the workup for Dr. Fennick, by the way.
Of course.
The same way you would start the workup for me.
you, yeah.
Yeah, and that's just with years of working with him. I'm like, well, let's go get a peripheral chromosome smear if you don't have any sperm. Let's get Y chromosome analysis. Let's get your testosterone levels.
Yeah.
Let's get an FSH level. Let's get a progesterone, a prolactin level. Let's get a thyroid panel. And then when he's seeing you, and I have all that data in front of him, he's coming up with a game plan.
Already.
Yes. So it's not like, oh yeah, go do this test and come back in another 2 months.
Yeah.
He has the data. I give him the data. He's coming up with a game plan.
I want patients to know that our efforts are collaborative.
Absolutely.
Right. And so
Yes.
I like how you say you refer to him,
Yes.
I refer to you.
Yes.
But they should know, and male and female, that
That's
there is
right.
a whole team
That's
working
right.
behind them.
Absolutely.
When I spoke yesterday, I had a lot of questions come up.
Mm-hmm.
One was egg donation.
Correct.
Another one was freezing their eggs.
Mm-hmm.
Is there a cutoff for you to accept an egg donor? And is there a cutoff, or how early do they have to start if they want to freeze their eggs? And we talked about, and you talked about this too, how women in general now, we are career driven.
Correct.
And we get in our career, we're waiting for Mr. Right.
Correct.
What if Mr. Right never comes?
Right.
Now we're in our early 40s, late 40s or whatever, and we want babies.
Right.
But we kind of missed that window.
You missed
So
the
I know
boat.
my question is kind of disconjuncted, but I want to make sure that we touch upon that. You know, should women start freezing their eggs in their 20s or 30s? And then what if somebody wanted to be an egg donor, and you know, what does that mean?
Good question. So what I want to do is first separate the two.
Okay.
Let's talk about women who want to freeze their eggs first. I think in your 30s is a good time frame to try to freeze your eggs. You know, between 30, 32, certainly before 35. But that doesn't mean it's too late after 35.
Okay.
It's just that your chances of getting mature eggs are lower, and you could get eggs that may not be as good, right? Your egg quality goes down with age. So yes, you can freeze it later. It's just that your chances are starting to diminish, and then you ought to realize that it's not a guarantee, right? You know, you're freezing your eggs at 38, 39. Well, you know what? When you finally thaw them, they may not actually work, right?
Okay.
So as long as you know that, right? As long as you're not under any illusions that it's a panacea, right? But then the sooner you start freezing your eggs, the better.
Okay.
And who can freeze their eggs? Professional women, athletes. I even have some patients who, they're married, and they're like, we don't want to start a family just yet. And they will do that, for instance. Or maybe the wife, I have a couple, one is in America, one is in Europe, so they freeze their eggs. It's giving yourself the options for later on.
Got it.
So you don't have that regret.
Sure.
Right? Now, would you freeze your eggs in your 20s? Not necessarily. That may be a little too early. But then I qualify it. If you think you have endometriosis.
I'm so glad you brought that up. That's my next question. Go ahead.
Yeah. Then you might want to freeze your eggs sooner rather than later. Now, I'll give you another example before we talk about egg donors. I had a lady who wanted to donate eggs for some dear friends of hers. So it was a directed donor. They wanted her, she wanted them to have her eggs. And I scanned her, and I said, she was 23, and I said, this is great, but if you do this, I'm going to tell you right now, you don't have a whole lot yourself. The next step you want to do is probably freeze your own eggs for you.
Yourself, yes.
Now, if she hadn't come forward to be altruistic, we wouldn't have seen that.
Yeah.
Right? So, anyway, who wants to be an egg donor? You really, the way I feel about egg donation is you really want to feel as if you're helping people. So a lot of my donors, I even like donors who are a little bit more mature, maybe in their mid to late 20s. And some of them have kids. My best donors have their own kids, and they go, I know I don't want any more kids. I have all these eggs, I can help someone else. They're mature.
Got it.
Right? I've turned people down who were immature.
Got it.
You got to know what you're getting involved in. And then I tell them, yes, we don't disclose your identity, but that doesn't mean they can't go on 23andMe and come knock on your door 18 years from now. How would you feel about that? You got to deal with that question. And then a lot of my donors will say, I don't mind. That's fine, cool. I have a donor who was of Greek background, and the parents, the mother was of Greek background. They wanted that kind of donor. They found her and flew her in, and she's delivered now, and they have an ongoing relationship. Wow. But those are the conversations they had before.
Got it.
Right? And that donor, she's not donating anymore. She specifically says, I will only donate for people who let me be involved in their lives. And they were looking for someone who wanted to be involved because they said, look, you know, I want my daughter, my son to know their root, their origin. So you have to have this conversations. And we have a psychologist actually for both the parents and the donor.
Oh, really?
Yes.
Love that.
You got to sort this out. And then you have a genetic counselor who needs to sort certain things out. And I know some people buy eggs from overseas and everything, and it's disconnected. You just don't know where those eggs came from. You don't know if those women were trafficked, coerced into giving their eggs, right? That should never be, right? It's not about the money part.
So you think of things as a reproductive endocrinologist that's way deeper, right? You have all of these different entities coming together, and it's all for the patient.
Exactly.
I love that.
It's all about the patient. It's all about their families, you know, because they reach out. my oldest, this will give you chills. I got invited to a graduation party last year, my twins, from a couple that I had not only treated but coached them through when they gave up. And I was invited when their kids were 1-year-old, 5-year-old, finishing grade school, and they invited me when they graduated high school, and I was so proud.
Oh my goodness.
And those two, they're girls, Stella, brilliant in college now. And I told them, when you finish college, I want to be there.
Oh my goodness. So you followed them all the way
I follow
through.
some of my patients.
I love
And some
that.
of my patients reach out to me like on social media.
Yeah.
And, you know, if I have a baby reunion, I don't know, it's good. But you're touching people's lives.
Sure.
So it's not just numbers. And that, I guess that's what has been the whole ethos for me in my practice. I'm touching people's lives. Now, you know, some patients may not want that, and that's okay.
Yeah.
That's okay.
That's fine.
Right.
Yeah.
Right. And there are other clinics, right? But then there are some people who want to know that you care on a deeper level. And
agree.
that's where the fulfillment comes in.
And that's the empathy that
Yeah.
I want my patients to get when they're going to a specialist. Sometimes when we send our patients out, we don't know what they're getting. We just know, hey, they can help you have a baby. But to know that you have that ethos and that empathy and you really do care is really
Right.
important
Right.
to me. And that's what I kind of want our listeners to know, is that you exist. Again,
you.
I'm like,
Thank you.
I can't believe that I haven't seen you in 11 years. But one thing you brought up that is really, really important to me is to talk about endometriosis. Can you explain to our listeners what it is, why it's an issue for fertility? I mean, I get these questions all the time.
Yes. So the simplest way to think of endometriosis, and I tell patients, think about when you have your menstrual flow. It's supposed to shed out of your body. It's supposed to come out.
Yes.
Imagine this menstrual flow that's supposed to come out flowing back the other way. Or we're still penetrating into
Other things.
the uterus or penetrating into other things. It's not supposed to be there. And your body knows that it's, you know, hang on, this is not supposed to be here. So then your body attacks it. It's trying to clean it up. Roto-rooter. Right?
I love that. I'm
Yeah.
going to use that in office.
Yeah.
Rotor. I love it.
But here's the problem. The army that your body engages to fight off this invasion cannot distinguish between that part that's not supposed to be there and the part that's supposed to be there. So you get what is called an inflammatory reaction. And it's just like your body is going to battle against itself. And you see this endometriosis spreading out into the pelvic cavity, even into the ovary. That's even worse. We could talk forever about where it's located. It causes serious inflammation. And that inflammatory response can cause a lot of scarring. And also, all the inflammatory tissue, that's the cytokines or the enzymes that are produced, they can actually attack your eggs too. So egg quality goes down, right? And heaven forbid, it penetrates into the muscle. Then it starts to harden your muscle, the muscle of the uterus up. You get adenomyosis.
Oh, yeah.
And they can't even implant a regular pregnancy. So it's tissue that's supposed to be shed, except it's located in places it's not supposed to be, either by retrograde flow or by de novo, or by the body just deciding, I'm going to create this menstrual pattern right close to the bowel. Well, then all the things in the bowel stick up. And you probably know when you operate on patients like that, we call it a frozen pelvis.
We call it frozen pelvis.
And I tell patients what a frozen pelvis means is that imagine somebody pours crazy glue into your pelvic area and stirs it all up, and everything's all mashed up together.
And that's exactly what it looks like.
Yes.
Yeah.
And it's awful.
It's awful.
Yeah.
So how would you counsel these patients? Now, to go back, you know, we treated
Yeah.
as a generalist, the best that we can.
Correct.
Right? And what I tell patients is that the way to truly diagnose this is to do surgery.
Correct.
They'll stick a camera in their belly laparoscopically and take a look and try to treat it that way. However, clinically, we can see what these patients are doing. We can treat them clinically with at least invasive first. So by the time that I've done whatever my treatment options are, you know, medications or Lupron or whatever, when they get to you, I feel like it's a challenge for you.
Yes. I got a call from a patient. Well, not from the patient, actually. Blue Cross Blue Shield called me because someone would take this patient. She had breast cancer and wanted to freeze her eggs. They're about to do chemotherapy, except she had this humongous endometrioma. It's about 8 or 9 centimeters.
Can you explain what an endometrioma is?
Yes. Thank you so much. Endometrioma is when the endometriosis goes into the ovary, and then it tries to shed as if it's in your uterus shedding out, except it's shedding into itself and just kind of expands. So you have all these menstrual blood that's shedding into itself, and it starts to darken up. It looks like a thick chocolate cyst, and it's just, it has nowhere to go.
Correct. Okay.
It walls itself up, and it just expands, and it can actually start to chew up the normal eggs present. And so this lady wanted to freeze her eggs. She had this humongous endometrioma, and I knew we didn't have time to go do an exploratory laparotomy and, you know, clean out the pelvis, and she had to get to surgery, chemo. So she, again, this is what I talk about, like collaboration. I called her gynecologist, who was in Baltimore, and I said, here's what I need you to do. I know you can't do the proper surgery because we don't have time, but can you drain this endometrioma, which normally you don't want to do. Right? You don't want to do it because it can form an abscess. Right? That's a big no-no. But she did a pelviscopy, drained it, reduced it, and when she did, from a patient that I could not see any follicles, her antral follicles started to pop up. I was able to stimulate her right away
and get some,
and get like 13 eggs from her.
Awesome.
Before we now handed her over to our oncologist colleagues, who now took it up from there. And it was really a total coordination and a dance between me, her gynecologist, her oncologist, the general surgeon, to get her the best possible treatment on an urgent level. And she just happened to have the worst case scenario: endometriosis, breast cancer, trying to freeze her eggs.
That's lovely, though. That's a good story for hope. Right? A lot of patients, sometimes when they come to you, they feel hopeless.
Exactly.
That leads me to my next question. What if fertility doesn't work? What do you share with your patients? What are the options?
So one of the things that I like to talk to my patients about is, why are you doing this? What is the point? What is the reason? Why are you going through fertility treatment? What is the root reason of you trying to do this, right? So if you track back, the reason is because you want to become a parent, a mother, a father, right? I mean, that's the whole point. I come from a culture where such a high value is placed on having someone there for you in your old age, having children. So I tell my patients, let's not lose focus of what you want to become, i.e. a mother, right? If we define your goal as being a parent, do you get where I'm going?
Oh, yeah, absolutely.
Yeah.
Absolutely.
So then open your heart.
To be a parent.
To be a parent.
Yeah.
Because
however which way.
Yes.
Got it.
You know, there are embryo donation. There are people who've donated their embryos. And I have quite a few patients who say, you know what, I don't want any more kids, but I don't want to throw my embryos, I want to donate it.
What's the difference between egg donation and embryo donation?
Embryo donation is someone who already has an embryo formed, fertilized egg, sperm put together. We have an embryo, we know it's good. And then they said, you know what, I want it to go to a couple that's deserving. So I'd rather donate this embryo.
Got
right?
it. Okay, yeah.
And then, of course, before we segue into that, adoption. I have a patient who, one of my favorite patients, if you were to see her and her daughter, you would never know her daughter was adopted. I mean, Barbara Walters, her daughter was adopted. People didn't know until she started talking about it on Mother's Day.
Yeah.
It was when I found out.
Because that's
right?
your child. It doesn't matter.
That's your child.
Yeah.
That's your baby, right? I mean, Mike Tyson, right? He was raised by a white woman, right? And to her, that's her baby.
That's her baby. Which I didn't know, by the way.
Yeah. So open your hearts to what you want to become.
Okay.
Have that vision. Don't close your heart off.
I love that.
Yeah.
As we wrap up, what are some of the take-home messages that you would like to tell the audience, tell your patients, tell clinicians?
Yeah.
What is your take-home message?
I think that I would tell my patients, start having the conversation. Again, what vision do you see for yourself? Do you see motherhood in your vision down the road? Well, start making plans right now, right? If you know you want to become a mother and you're 32 and you're still not settled, think about freezing your eggs. One of my favorite patients she's also a family friend. She's 30 years old. She's an actress. And she goes, Dr. Famiua, my career is not where I need it to be yet. And I told her, like I was talking to my daughter, I've known her since she was a baby. Child, let's freeze your eggs. Right? Start talking about it. What do I want to tell to the OBGYNs? Start doing the preliminary test. Engage your patients. And if they say they're not ready, just tell them, hey, listen, we can talk about this next time you come in, but I want you to start thinking about this. And I'll ask you again when you come back in 6 months. You know, just start my friends, because I've trained them over the years. And I tell them, please, you know, start engaging these patients, start asking them questions. Shout out to Dr. Tamara Coates, she's super, love her. But she doesn't waste time, she doesn't play.
Yeah.
She gets them the patients in. So not just OBGYNs, primary care doctors, start having them think.
Well, thank you so much. I appreciate you being here.